It was just merely a first talk of the day, and it feels like there's tea time already with all the hustle and bustle. Good morning, everybody. My name is Po Heng Chong. I come from Singapore. I can't remember how many times I've been to this conference. It continues to be awesome, and I'm so glad to be able to chair this segment of the conference with Julia Downing, who will introduce herself, but actually she doesn't need any introduction. Well, this is the segment in the conference where we'll be spotlighting a particular topic around measurement. So I do remember a management consultant, Peter Drucker, who I think is Austrian by birth, and he's an American economist, educator, as well as a book author. So he said something that I remember till today, and I used it as a means of actually thinking about how service ought to be structured and monitored or tracked for results. So he said that you cannot improve anything if you don't measure it. So therefore, it becomes really important for anybody who's running a service to think about the tools that you could use to begin to measure the results that you are hoping for towards the goals that you're aiming. Today we have got three distinguished guests who will be expounding this topic for us, and it's my pleasure to introduce our first guest from America, and this is Dr. Ananth Prasanna. I'm meeting her for the very first time. I just heard she is new to this conference, and I'm quite sure you will give her a very warm welcome.
Thank you so much to the Maruzza Foundation and to the Congress organizers for inviting me to give this talk on quality of care assessment tools. First, I just want to share a few disclosures. So I am a pediatric oncologist, and I practice at an academic hospital in the United States. I also study quality of end-of-life care for children with serious illness, with a particular focus on children with terminal cancer. I share this mainly to let you know that this is the lens with which I approach my work. So you will hear a lot about measuring quality of end-of-life care for children with cancer. And I invite you throughout the talk to think about how these tools might be leveraged for different populations of children with serious illness and outside of the United States. All right, so my objectives today, in 20 minutes, are to discuss what patients with serious illness and their families define as high-quality end-of-life care, to explore traditional and novel modalities of quality measurement, to briefly share findings from recent studies exploring quality of care for children with advanced cancer, and then to describe some of the limitations and opportunities for innovation. The late Dr. Randy Curtis, much beloved, spoke at the 2022 State of the Science in Hospice and Palliative Care meeting, and he quoted Lord Kelvin saying, "If you can't measure it, you can't improve it." He also quoted Albert Einstein and said, "Not everything that counts can be measured. Not everything that can be measured counts." So I think this sets the stage for us to discuss the current state of quality measurement in childhood serious illness care. At least in the United States, we do not systematically measure quality of care across the illness trajectory for children. Many programs have instituted approaches to assess patient and family satisfaction, but these assessments are not necessarily standardized, and cross-program comparison doesn't typically occur. And we also know that there are a lot of problems associated with assessing satisfaction, including the ceiling effect, so patients and families are likely to rate their programs very highly. In my humble opinion, this absence of quality measurement stymies efforts to improve delivery of pediatric palliative care. So what do we know taking you back to my context in terms of children and adolescents with serious illness and end-of-life care, we know that these children receive highly intensive services near the end of life. This includes substantial amounts of time spent in the hospital and a lot of invasive procedures and surgeries. These data have been derived largely from US-based or North America-based administrative claims data sets. So these data sets are very limited. They primarily characterize use of hospital-based resources. So if you're interested in what happens in the home, or if you're interested in and curious about who's referred to hospice, these databases unfortunately don't have all of those answers. And then at a more granular level, what really frustrated me in pursuing some of this work myself was that I didn't know what kind of care these children were actually receiving. I knew that they were spending a lot of time in the hospital, but that says nothing really about the quality or the experience of care. So this drove me to some of the core questions that I've been asking in my work. What constitutes overly intense care? If we look at the adult data, spending a lot of time in the hospital, receiving invasive procedures, or spending a lot of time in the intensive care unit would constitute poor quality end-of-life care. But can we really extrapolate from adults? And conversely, what defines high quality or good end-of-life care for children with serious illness? So to start to answer this question, we embarked on a dual-center qualitative study a few years ago. We engaged parents, including bereaved parents and parents of children with advanced or incurable cancer, adolescent and young adult patients with advanced cancer, and interdisciplinary clinicians. And we asked them to tell us what they thought a healthcare team ought to pay attention to when a child with cancer is near the end of life. These are some of the key themes that arose from this qualitative study. First, families and interprofessional specialists told us that it's very important to meet family preferences, including for the location of death, if possible. They recommended avoiding intensive resuscitation, engaging an interdisciplinary team, including palliative care and hospice services if available, optimally managing symptoms, and a lot of times families talked about physical symptoms more so than existential or emotional symptoms, and then direct communication, including communication with a child when appropriate or age appropriate. So what we did from the core themes that arose from this qualitative study is we arrived at a long list of 28 attributes of high quality end-of-life care in a couple of key domains. And what we did was we used conventional approaches to transform these attributes into quality measures, so with a specified numerator and a denominator. And then in order to sort of understand better what was most important to measure, because as you can imagine, any sort of tools that we develop to measure quality in this context, it would be very difficult to measure 28 things. So we embarked on a couple of different studies to try to narrow this longer list of potential quality measures. The first was a modified Delphi study, in which we conducted a 2-round electronic survey engaging interdisciplinary healthcare professionals and bereaved parents to help us narrow this longer list of potential quality measures. We asked the participants in this study to rate each potential measure on importance on a 1 to 9 scale, with 9 being most important, 1 being least important, and then also feasibility of measurement with the tools that they were aware of, or the electronic health record, et cetera. In this study, what we found was that about 17 of those 28 potential quality measures were deemed to be highly important. But what you can see on the right panel is that, unfortunately, the most important quality measures were also deemed the least feasible to measure. We then pursued a discrete choice experiment, which is a quantitative approach to try to narrow this longer list of quality attributes or quality measures. And we can talk offline about how to actually do this study, but essentially what this allows us to do is to sort of, in a weighted fashion, rank order the longer list of quality measures. In this particular study, we engaged bereaved parents from across the United States. So what is most important from the perspective of bereaved parents? Symptom management, feeling that a child's needs are heard, and then having an end-of-life care experience that matches goals and preferences. Not altogether surprising, but it was very interesting to see what rose to the top, and then also what was least important to these families. They told us that what was least important was avoidance of chemotherapy use, the intensive care unit, cardiopulmonary resuscitation. So all these things that in general, at least in the adult literature, are considered to be bad or poor quality care. Families in this context didn't feel that it was important to really assess that or track that. They also felt that it was less important to provide or seek psychosocial support for themselves in the moment. And this is not saying that psychosocial support was perceived as unimportant for them overall, but in the last weeks or months of their child's life, they deprioritized themselves quite a bit. So in terms of implications of this study, bereaved parents prioritize end-of-life quality measures that are focused on symptom management and goal-concordant care, deprioritizing their own psychosocial well-being in that moment, and then feeling that quantifying or limiting healthcare use is far less important. What these studies collectively do is they inform future patient-centered strategies to measure care attributes that matter most to families of children with advanced cancer. So we pursued a couple of different lines of work to try to develop some tools to be able to measure care quality in a number of these key domains. The first was a questionnaire that we are in the process of developing called the Pediatric Cancer Care Experience, or PACE questionnaire. We began with a very extensive literature search looking for existing validated instruments, and we found over 90, most of which were developed for adults, not surprisingly. And then we created a draft instrument for parents of children with advanced cancer. So in this early stage, we're just limiting this questionnaire to parents. We assessed face, content, and cognitive validity, engaging families and interdisciplinary professionals as well, and then conducted a pilot study across the United States at 8 major centers, involving 158 parents in total. Right now, we're in the process of analyzing the data and also conducting an exploratory factor analysis. But just to give you a sense of the types of questions that we're asking the extent to which families feel heard and understood, and their children feel heard and understood if they're old enough to be able to express their wishes and preferences. We're also asking very briefly about symptoms, so it's not a very extensive symptom assessment. We're very curious about communication with the oncology team, so we ask a number of questions around that. And then we also inquired about the nature of their interdisciplinary team. So what sorts of services are they receiving? Is there continuity of that healthcare team? And right now we're engaging in an exploratory factor analysis, so some of these items may fall out of the final instrument, but I'm really pleased to say that a bulk of the items actually are able to stay in the instrument overall and are robustly measuring outcomes like communication and symptom management and feeling heard and understood. So just to give a snapshot, I won't go into a lot of detail about the results of this study because we're still in the process of analyzing. But in terms of feeling heard and understood, some of the questions that we asked were, I felt heard and understood by the oncology team. I felt that my child was heard and understood by the oncology team. I felt that the oncology team put my child's best interests first when making recommendations about my child's care, and so on. There are a couple of agencies in the United States, including the RAND Corporation and the American Academy of Hospice and Palliative Medicine, that have actually widely tested some of these questions, adapted for adults in ambulatory palliative care. And they have received endorsement from major organizations in the United States to be able to implement these questions across the country in ambulatory palliative care practices. These questions have not been tested in children, but because there's so much appreciation for asking these questions, a lot of pediatric palliative care programs are now adopting these questions without actually having tested or validated these particular items for children. So I'm hopeful that having run through this pilot study and validating these items, we may be able to more broadly disseminate at least this portion of the questionnaire. And what we're also able to say, I mean, you can see in the blue and the green how many people feel that these questions, they would respond to these questions as very true or completely true. So in general, people do feel heard and understood, and we're not identifying a ton of gaps. More wider dissemination of this instrument may identify some problems along the way. As I mentioned earlier, we were able to look at who is involved in the interdisciplinary team. And there are other modalities. For example, you can use administrative claims data to look at whether a palliative care team has been involved. But what we've found in some of our earlier analyses is that some of these data sources are not that reliable in terms of reporting who has been seen by a palliative care team, who is receiving hospice care. And so directly asking families is another way to access that information. And what we found in this study was actually not that many children were receiving appropriate psychosocial care, which really falls below some of the national standards that we have in terms of interdisciplinary involvement in the care of a child with cancer. We also asked a number of questions about communication, and I know the font is very small, so it's hard to see. But what these questions were getting at were aspects of healthcare team continuity, goal concordance, within team communication, and communication of the healthcare team with the family. And what we were noticing, just in terms of some signals that we're noticing, are that there aren't as many discussions around uncertainty or what lies ahead in the future. This was how we asked about prognosis, because the word prognosis meant nothing to a lot of families. And so we asked about it in sort of a slightly tangential way, and found that teams were maybe not quite so good at discussing what lies ahead. Another tool that we've been developing, in addition to this questionnaire that really gets at parent-reported outcomes and experience, is we've also been working to develop a rule-based natural language processing pipeline. So where the questionnaire allowed us to prospectively assess quality of care, natural language processing, at least in our initial study, was used retrospectively to look back on the care that a child with cancer received near the end of life. What natural language processing does is it greatly expedites chart review, essentially. It's not fully automated like large language models or machine learning that we hear a lot about, so it does involve a human in the loop, as my collaborator likes to say. And at least getting started with natural language processing is actually person intensive. But once you've sort of developed the pipeline, it can greatly expedite searches through vast compendiums of medical records in the electronic record. So we conducted a study that we just actually completed and published at a single center. This was essentially a proof of concept study. We included 101 patients at my institution who had died of cancer-related complications over about an 8-year period. And we extracted clinical notes in the last 6 months of life for these patients. So it amounted to over 28,000 interdisciplinary clinician notes. And then we were able to look at any instances of documentation of goals of care, palliative care, hospice, life code status limitations, and then preferred location of death if it was documented. So notice that I keep saying the word documented, because one of the major limitations of natural language processing is if it's not documented, we can't find it. And then we used a publicly available system of natural language processing to be able to sort through these 28,000 clinical notes. So just briefly, what we found in this study, or what we were able to do in this study, was to ascertain the proportion of patients who had any documented discussion around these particular quality measures. So over 80% of patients had some documentation around goals of care or limitations to life-sustaining treatments. Nearly 3/4 had some sort of mention of hospice. So this doesn't help us ascertain whether a patient was actually enrolled in hospice, but if there was any documentation around a conversation discussing hospice, then we were able to capture it in this study. We were also able to ascertain the average time from the first documented discussion of these outcomes to death. So through this approach, we were able to say that most of these conversations, at least the first instance of these conversations, were happening more than a month before the child was dying. So to close up, I shared with you 2 novel modalities and also some of the limitations of these modalities, and then also the limitations of administrative claims data, which historically have been used really widely to assess quality of care for people with serious illness. In conclusion, I would just like to say that focusing on quality of care assessments, particularly on hospital use, is really insufficient and doesn't really measure what matters, at least based on the data that we have developed and put out there. These novel approaches to measuring quality of care add nuance and family-centeredness, but we really haven't yet scaled these tools nationally or internationally. So with that, I would like to acknowledge all of my funders, collaborators, and I would like to give a special acknowledgement to my mentor, Dr. Joanne Wolf, who has been my mentor for probably close to 15 years now, life mentor, career mentor. So for all of the junior people in the audience, you need to find a mentor like Dr. Wolf to help you, to help shepherd you through this career. Thank you so much for your attention.
Thank you, Dr. Ananth, for the most fascinating talk. The findings are almost like hot off the oven, almost. I forgot to mention that Dr. Ananth Prasanna was named one of the emerging leaders in 2024 by the American Academy of Hospice and Palliative Medicine. Congratulations. It's time for question and answer, if you have any. Please grab the opportunity because we only have got 2 minutes before the next speaker comes up. Yes, please. Please introduce yourself and where you come from.
Yes. My name is Francesca from Italy. I'm a pediatrician. Thank you for your work. It was really interesting. My question for you, especially related to the first questionnaire, is how do you manage to communicate and convey all of this useful and important information to the other colleagues, a member of the team, also and especially member of other teams like PQ doctors? Okay, thank you.
Thanks so much for that question. So in terms of engaging other clinicians, in our qualitative work, we engaged a number of ICU clinicians, including nurses and physicians, and then also engaged chaplaincy, palliative care teams, psychosocial clinicians. So we were really trying to get broad perspectives. In regards to how we communicate in terms of the gaps in care, is that what you're asking about?
It's not working? Okay. Do you use a sort of checklist or chart to convey the information in a quicker ways?
I have not personally developed a checklist or some sort of a guide, but I know a lot of people have been developing communication guides that help both the families and the clinicians guide through these conversations and hit the high points. In some cases, I've even seen communication tools that use pictures and engage families even in advance of the conversation to think about what their preferences are, and so essentially a pre-meeting, but that's not, unfortunately, the focus of my work. So.
Congratulations, great work. I work with quality as well, and first of all, I'm sad that you said the parents don't care about the ICU. But the conclusions that you came up with, fascinating. They are the same conclusions that many of the quality studies looking at families, giving interviews, quality data has brought us back. Honesty, communication, team communication, you know, all these things. So how do you match these two, the quality studies with your quantity studies that you're doing?
In terms of how I've communicated, essentially I've been saying all along that we are finding in different modalities the same thing. So in essence, it helps to validate the findings of prior studies. And looking back on the adult literature, at least in the early 2000s, where some of the quality measures were developed for adults with serious illness and cancer in particular, a lot of our findings actually echo the findings from those adult studies as well. But what happened in the adult world is that they were focused on feasibility of measurement. And so a lot of these quality measures are most measurable in these large databases. And so they focused on what they could measure at the time, and you know, in some regards, neglected some of the more patient-reported or family-reported outcomes. And now there's been a big push to try to measure family-reported outcomes and experience in large surveys. But early on, that wasn't sort of the focus. So the way that I see it is that what we're finding, the fact that it's not that different actually is very reassuring and supporting the findings of earlier studies.
Thank you, Dr. Ananth. Last call for questions? Yes, absolutely last one.
Thank you very much for your presentation, which was really inspiring to improve our work. Yesterday we had a fantastic talk about cultural differences regarding how we approach patients. Do you believe that, or have you studied how cultural difference amongst family might change the value or the importance of these indicators, or do you believe that they will stay the same? And if not, how we can approach that to get the better healthcare for each cultural background or each family? Thank you very much.
I'm gonna have to ask you to repeat your question.
It's simple, sorry. If you believe that differences in cultural backgrounds may change, what are the important indicators for each family?
I don't know. We tried to strive for, at least within the United States, we tried to strive for diversity in terms of the participants in all of our studies in regards to race and ethnicity. So, you know, amongst my colleagues, we've talked a lot about whether any of the findings would differ. In particular, in the discrete choice experiment, it was largely white women who participated, and that was a huge criticism. And so we, you know, in thinking about how to explain this study or how to justify the population that participated, I was talking with my colleagues about whether the findings would change, and what we kind of arrived at is that probably some of the quality measures that were in the middle, that were variably rated. For example, psychosocial support for siblings was kind of in the middle. Even palliative care was, you know, 10th or 11th in terms of importance. And so some of those particular quality measures may differ depending on the context or the population that we're asking. But I really think that the things that came to the top and the outcomes that were deemed least important probably wouldn't differ depending on the population.
Thank you. Thank you for all the questions, and I'm going to pass the mic now to my co-chair.
Thank you. Good morning, everyone. It's great to be here again this morning. There was so much energy yesterday, and let's hope that continues today. Also, I bring you greetings from our friend and colleague Huda, who was unable to join us from Lebanon today. So that's why I'm chairing in her place. And I'm now really delighted to introduce another friend and colleague who I've worked with for many years, Professor Richard Harding from King's College London. But his work takes him all over the world, and he's going to talk to us about using outcome measurement in paediatric palliative care. So thank you and welcome, Richard.
Good morning, everybody. First of all, thank you for the kind invitation to be with you today. And I'd like to share the story of a very long program of research. I was thinking this morning, it's about 7 years, I think, that we've been working on this. A very complicated program of research. Methodologically, it's been very challenging, but also it's a story, I think, of real partnership. We've had children and families advising us every step of the way through the years. Partnership with clinical services, but also, as I'll conclude at the end, a real global partnership focused on outcomes. So just to focus us on the topic, outcome measures, what are they? They are tools which help you assess the change in somebody's health or well-being that you can attribute to the care that you deliver. Ideally, they're patient-reported, but you can have patient-centered measures and you can have proxy reporting, a parent or a carer or a staff member. You can also have measures that assess the health and well-being of family members as well. So it's a really important first step to be able to determine whether what we do makes a difference, but also to enable us to conduct research and measure outcomes. So what we do at the individual level, it helps us identify patients and families with needs, monitor them, inform care planning, facilitate communication between teams, but also at the service level, it helps us understand our population, conduct audit, research, make sure we deliver the services that matter and reflect patient and family needs. There's a long history of the use, the development and use of outcome measures in adult palliative care. And more widely, particularly in oncology, there's been quite a lot of research to measure outcomes and to understand the benefits of using outcome measures as well. And we know from the existing literature that if you've got a valid outcome measure and that you use it in routine practice to identify, communicate, care, then you can improve service quality and improve the patient-centeredness of services. You can better recognize symptoms. You can increase the number of referrals, and you can improve quality of life. So there's been a long history of papers saying we need to do this in children's palliative care. And I see Anne Goldman's here, and Anne was one of the first people in the UK saying that this needed to happen. So there's been a long history of saying we need to do this, but it's quite a challenging thing to do. So it began more recently, and it's great that Julia's chairing it because chairing this session because Julia started the development of children's outcome measures in Africa, and I had the pleasure of working with her on that. So going back to the beginning of the research program, so Lucy Coombs is a children's palliative care nurse consultant in London. She did the master's degree in palliative care with us at King's, and for her dissertation, she conducted this systematic review of quality of life measures for children's palliative care, and that review concluded that there wasn't an existing measure that captured what matters to children and families in the context of palliative care. I've put the QR codes on every slide, so whenever you see a QR code, that's the paper that I'm describing, and I believe that they're all free to access. So every time you see a QR code, that's the paper. So this first review by Lucy identified the need for us to develop something that was specific to the context of children's palliative care. So the overall view of this program of research is to develop a family and patient-centered outcome measure for children and young people with life-limiting and life-threatening conditions and to evaluate its psychometric properties. So it's a very long mixed method study, first of all developing the tool, then validating it, and then working on the implementation science for the outcome measure. And we use the best principles of tool validation. So any of you that are into psychometrics, we are following the COSMIN and the Rothrock guidance on outcome measure development and evaluation. So first of all, we had to get people together and say, do you want to do this? How should we do it? What should we take into account? So we started with a meeting of 36 clinicians, advocates and researchers to get their views on what should we measure, how should we measure, what does it need to do for you in your routine practice, and just to start creating a coalition of people who wanted to develop outcome measurement. So that kind of started bringing everybody together. And then when we moved into the development phase, we started with a qualitative interview study to understand what people said mattered. So we conducted 106 in-depth interviews with children, young people, with parents and carers, their siblings. That was a very clear message from the outset of this program, that siblings matter. Commissioners, which are people within the health system who design and assess the delivery of services, and then health and social care professionals. So we asked people, what should we measure? What matters? So when we take the domains of physical, psycho-emotional, social, and spiritual, you can see here some examples of what matters, and following on the excellent presentations yesterday, cultural beliefs and needs came through very clearly in spiritual and existential concerns. In fact, we've published that paper as well on what does spirituality mean to these children and young people, living a full life, meaning of life, social and practical issues around provision of services, friendship, ACP, which we heard about yesterday, hobbies and play, and balancing the needs of the family, psycho-emotional stuff, particularly access to support and access to emotions and to be able to discuss them, and then the physical symptoms, which I'm sure you would anticipate. And then this whole concept of normality, which is really quite complicated. Issues around not knowing any different, wanting to return to normality, as well as establishing a new normal. And also, of course, during all of this, we had the challenge of COVID, and we published a paper on what that really meant to children and families during COVID, being socially isolated and not having access to their networks. Then we've just heard a Delphi study in the first presentation, then we did a Delphi nationally. Once we'd got all of those comments about what might need to be measured, we then did a round of Delphi surveys to try and understand how we reduce that down, because an outcome measure can't measure everything. It's supposed to be brief, but address everything that needs to be addressed. So we need to reduce down to what the core outcomes should be. So we did that. Then Lucy went on to do her PhD on this, having done her master's with us. So Lucy did a really fantastic systematic review about how we design measures with children. So she looked at all the evidence for the recall period, for the response scale format, modes of administration, and what do you do to enable children and young people to complete questionnaires. This was not specific to palliative care. It was a very broad review about what we know about measuring health outcomes for children. And you can see the recommendations there, and the recommendations from this review certainly informs the design of the CPOS, the Children's Palliative Outcome Scale. So once we knew what mattered, and we'd brought that down, and we'd understood what needs to be in the features of an appropriate measure, then we had the item generation. So we did this with the Children's Advisory Group, with parents, with researchers, with clinicians, to bring down the CPOS into the core items. But of course, we have to have versions of the CPOS. So we've got proxy versions, and then we've got 3 further versions, which I'll show you in a little while, that can be according to age or developmental stage. So that was the item generation. And then we can see the domains map on, as you would expect, to the definition of palliative care, so the physical, social and practical, emotional and psychological, spiritual and existential, and then the domains for the parent-carer items as well. So the validation. So cognitive interviews, very important. So cognitive interviews enable you to determine, Do people interpret this in the way I intended? Is it readily interpretable? Do people find meaning? Can they use the response levels? Does it seem to cover what matters? So we did a number of cognitive interviews with parents and carers and children and young people to give us the final version. So we've got CPOS A, which is a parent-carer version for children who can't self-report, for younger and non-communicative children, and then CPOS B for older children, those who can communicate and parents can work with them. Then we have Mercury, which is a recall of yesterday and today on a 3-point response format. Saturn, which is recall of the past week with the 3-point response format. And then for the older children, we have Neptune, and the children themselves chose these names, but the advisory group chose planets. In Africa, the children have chosen birds to name them. And then Neptune is recall of the past week with a 5-point response format. And all of these design issues were directly informed by the systematic review of health measurement with children and young people. So now we're in the phase of psychometric evaluation, so we're delighted that's just closed to data collection in the UK. So we're trying to determine the psychometric properties, so is it valid? So does it measure what it's supposed to measure? Is it reliable? So does it measure things accurately? And is it responsive? So if a child's health status changes, can the measure pick up that change? So the analysis is underway at the moment, and we've got a great team working on that. I'm delighted to say that 529 people have participated in the CPOS validation study, including 105 children and young people, 347 parents, and 77 health and social care professionals. And you can see there the numbers of people who have responded to each of the versions of the CPOS, and they've done so twice over a 2-week period. And we're also measuring within that a measure of phase of illness as well. So what's it been like for people participating in this? I enjoyed the questionnaire. It gave me something to think about, and it's something my son really enjoyed. He liked the idea of helping the people that help him, so listened and sat nicely. Thank you. The questionnaire was difficult to answer the first time as I got upset, but I understand that this is research and you need the information. And this has been very interesting in interviews with parents. A couple of parents have said, look, I found these questions distressing, and that's why they're the right questions, so I'm glad you've asked me. You're asking me what matters, and I think that's really, really crucial. It helped me assess my psychological and mental health as a carer and parent. So it's that useful process about being asked about the things that matter. What did children say? It's nice to be asked and feel important. I found the questionnaire easy to answer. It was good because the questions were good. It was good to think about my condition. I liked the smiley faces. I had help from my dad, but I understood the questions and I liked the emojis. So the children's view in this is utterly crucial. So now we have a systematic review about how you implement outcome measures in child's health. So this review was to identify and synthesize the evidence of what works to implement person-centered outcome measures into pediatric healthcare. So there are a number of issues that tell us how you do it, because that's the really important bit now. How do you do it? And then in the interviews, we've also asked children, families, and healthcare professionals about what might be the benefits, risks, barriers, and facilitators of using outcome measures in routine practice. So we've got a whole series of recommendations on what you should and should not do, which is really crucial. Outcome measures on their own do nothing. They only have a benefit when you read the answers, use them, discuss them, use them in care. So we have a real sense now of how to move forward with this. And then lastly, something that was entirely unplanned and I'm so delighted about is that this has become a real global network of people developing outcome measurement and looking forward towards implementation. So the African CPOS, which Julia thought of many, many years ago, it's now being implemented in Uganda with Eve Namisango, and we have funding for implementation in Malago Referral Hospital, Kawempe Home Care, and Mildmay HIV clinics. So they're using CPOS. It started about a month ago. It's become part of routine practice, which is great. Then we got funding to work in the Middle East, and we worked in Jordan and Turkey in oncology clinics there, and we've been developing outcome measurement for children's palliative care there, particularly focusing on refugee children. I see Ross is here somewhere. We've been working in New Zealand and Australia, who are also doing a validation study with us on CPOS. And then lots of other people that we've been working with in Singapore and Korea, Japan, Taiwan, and there are plans currently for Italy, which is great. So this has been fantastic that people want to work with outcome measures. They want to be able to use something simple and valid and reliable to improve our ability to measure outcomes. So we've developed the measure. We should have some of the data for you early next year, the statisticians tell me. Never rush a statistician, so we're giving them their time. It's been the first time, the Children's Palliative Outcome Scale started in Africa, and now it's taken a real global dimension, which is fantastic. And of course, the next phase for us is implementation, because the measure alone, as I said, doesn't achieve anything. Its implementation can achieve a lot. So, thank you to, in the UK, all of these clinical services that have been working with us. Amazing partnership. Thank you to them, and thank you to everybody else that's participated. Thank you.
Thank you very much, Richard, and thank you for all the work you and your team have done over the years. As you've presented it, it's hours and hours and years of work. And so there's a lot there. Any questions for Richard? There's one over here.
Not really a question, just a comment. I'm amazed at the work that's come from one small conversation I had with Irene Higginson over a cup of coffee about what we really need to do. And thank you so much for doing it all, because it's clearly been massive, but it will be of such value for everybody.
Thanks so much. That's very kind of you, Anne. Thank you.
Any other questions? Over here?
Thank you. Really exciting. Is the goal of the tool to be completed by the patient and family, say, prior to a clinical assessment, to then drive the discussions and goals for that clinical assessment and therapy?
Turn my mic on. That's the really important point, is in your implementation plans, because outcome measures shouldn't disrupt your service. It should fit in your service and serve you. So it's about, within your clinic, working out where and when is the best place. So is it on an app, on an iPad that the family do it the night before and you meet the clinician? Do you sit with the children quite like the notion of sitting with their nurse, their doctor, their social worker, and doing it together. They quite like that idea. So it's about finding ways. I'm implementing outcome measures currently in HIV services in the UK. And it's exactly this conversation, going into every clinic and working out what works for you and not imposing a system. I think everybody's a bit worried that it's going to try and change the service in some way rather than it serving you. So yes, you can do it together. Yes, you can do it on an iPad. All of the above is entirely valid.
Okay, any other questions? I'm scanning the rows for the hands. Okay, we'll move on in a sec, but I also just want to encourage everybody, because all of this work came initially from a very small study and from small beginnings. And I think that's really important for those of us who work in many places where we perhaps don't have much research funding, we don't have time set aside for research. The small studies can lead to bigger things. So just to encourage everybody, go for it. Start small, go for it, and these things develop. And also to recognize that there's some other people in the audience who were involved in that initial study back in Africa that we worked on with Richard and the team. So, moving on to our third presenter, another friend and colleague, Professor Lorna Fraser, who's also a professor from King's College and London, and she's going to talk to us about opportunities and limits, and I'm looking forward to hearing this. Hopefully she's going to be challenging us for the future. So, welcome, Lorna.
Thank you very much, Julia, and thank you to the organisers for letting me speak after my boss. Isn't ideal, folks, but let's see how we get on. So I pondered about this title, about opportunities and limits, and I think mostly because I think we have a lot more opportunities and much less limits. So I'm going to focus my presentation around more of the opportunities that we have when we're thinking about how we improve and measure the quality of care for children with palliative care needs. So I'm going to talk a little bit about evidence-based medicine, the current evidence, pick up on some of what Prasanna and Richard have already discussed about measuring what matters, before having a little bit of a rant about robust evaluation and where I think we need to go. I'm illustrating this using examples. It's not comprehensive. If there's lots of randomized control trials that you guys are doing in palliative care and I don't know about it, please come and tell me afterwards. But as Julia says, I'm going to be a little bit challenging, so if I haven't made a few of you cross, I've probably not achieved what I want, what I think we need to do, rather than necessarily what I want to do. So I don't think I've met anybody in the last 15 years working in paediatric palliative care that isn't trying to do good. That's why we're all here. But just because you're trying to do good doesn't mean you're not doing harm. And I think that's really important. And if we think of the basic principles of evidence-based medicine and healthcare, I hope I don't need to persuade anybody in the audience of the value of evidence. We all have finite resources. We're working with the most vulnerable population of children in our own contexts, and we all want to be able to provide the best quality care for all children. And what that looks like will look very different in the UK than it looks like in North America, what it looks like in low and middle income countries. But we're all striving to do the same thing, and we all need evidence. We have national guidelines, the National Institute of Health and Care Excellence in England, and the first guidelines on end-of-life care, I have to be careful because Dr. Vickers, one of the co-chairs of this group, is in the audience, and I can see him just about. This was published, 8 years ago. I think we need to update it, folks. 8 years ago, and it was really important and really gave national guidelines for the first time in England for children and young people at end of life. But it also really drew attention to the fact that we were making recommendations mostly based on expert opinion and low or very low quality evidence. And we're also working in the context of quite a changing population. So this graph on the left is the numbers of child deaths aged 0 to 14 in England over the last 40 years. Coincidentally, rather than by design, the 1982 was when the first children's hospice opened, and then we had nearly 10,000 infants and children dying in England. We now have just over 3,000. The unfortunate slight uptick at the end there is we do have had for the first time in many, many years an increase in infant mortality within England and Wales, and unfortunately mainly due to government decision makings and impact of the social determinants of health. So this is good news, and in your own countries across the world you will see a similar pattern. The numbers will be different, but you will see a similar pattern, and that's great success. But if we take the second half of that graph and look at what's happening within England in terms of the numbers of children living with very complex life-limiting conditions, it's markedly increasing. Our colleagues in acute medicine, in critical care, in surgical specialities are very, very good at keeping children alive. We're using much more medical technology. We heard yesterday an excellent presentation. We're not just talking about gastrostomy tubes, we're talking about ventricular assistive devices, all these other things that are keeping children alive, and they have very, very high healthcare needs. And my feeling is that our systems, certainly in the UK, have not kept up with that increase in need, and as well as the increase in numbers of children. And this is some work we did for the Welsh government 3 or 4 years ago. So we are talking about a relatively small population of children, but they are very high users of healthcare. If you look on the right-hand side there, 7 in 10 paediatric intensive care bed days for children with life-limiting and life-threatening conditions. I've put this here for another reason as well, because I'm not sure I've ever heard a critical care colleague tell me they don't have enough children to do a randomized control trial or other sort of robust evaluation. I'm not trying to minimize the challenges we have. I think we just need to think carefully about some of the statements that we make and some of the assumptions that we make about what we can and can't do. So I'm going to give some examples around where I think we are with the state of the evidence. I think 15 years ago, we didn't have a lot of evidence. I think now we're very, very good at describing problems. When I say we, I'm including myself in this. I'm being as critical of myself as I am of anybody else. But we're very, very good at describing problems. If we look, we've just published a scoping review about the barriers and facilitators to referral and access in paediatric palliative care. There's 195 studies, more than 150, predominantly asking professionals what the barriers and facilitators are. I think we know the answer. I think we need to start doing something about it. And what those barriers and facilitators are very different if you're in a low and middle income country than if you're a high income country. Quite different if you're in a health system that's free at the point of care to one that's based on insurance and other mechanisms. And in the same review, we looked at the evidence around interventions, and there was only reports of 42 different interventions. I know there's more than that, but we're not reporting on it. We're not publishing on that. But only 17 out of those interventions had been evaluated in any way, and mostly low-quality evaluations, and a lot of focus on increasing professional understanding and measuring whether they understood more at the end of an educational session. And of course that has value, but does that impact on paediatric palliative care referrals if you still don't have a service, or you still can't access morphine? Or indeed, does it impact on the outcomes of the children that Richard and Prasanna have been talking about? I think we can do better. Some of us have already done better. So we have the PediQuest study. We have a randomized control trial that has been undertaken in paediatric palliative care for the first time, which, if this abstract is true, is showing positive outcomes. But we can do it if we work together. Symptoms. We all know part of one of the biggest issues for children and families is complex symptoms. And this nice paper from Chris Feutner and colleagues using the Adaptive Memorial Symptom Assessment Scale. We have a way of measuring symptoms in children, and you can see the very high prevalence of pain, lack of energy, irritability, etc. But we also know that these kids have polysymptomatology. The median number of symptoms was 7 for this group, but the range was much larger than that. And we know that for some studies, particularly some research, some randomized controlled trials about pharmacological interventions, that would mean that many of these children are ineligible. And I think we need to think differently about how we're assessing effectiveness of drugs in our population. But we know that actually that's not the only problem in terms of symptom management. There's lots of other issues around education and access to medication, etc., that are also really important. But again, we're starting to get there. I don't know if anyone in the audience is involved in the DIPPER study led by Ian Wong and Emily Harrop. They've done a very thoughtful and systematic process of assessing feasibility to undertake a randomized controlled trial. I think we no longer have the diamorphine, which is a little bit of a problem. But what they have shown, and they have agreement on the outcome measures, the way to assess pain in children and young people. They've got agreement that, and it's shown it is feasible to do an individual level randomized control trial to answer the question. And we also know, again from the NICE guidelines I mentioned earlier, but also the guidelines on management of chronic pain in children, that we know the questions we need to answer, and we need to start using robust evaluation methods to do that. Parent care or health and support is something I feel very strongly and passionately about. There's this sudden expectation, often overnight for parents, that they will become healthcare providers as well as parents 24 hours a day, 7 days a week. And I've spent the last 6 years describing the problem. Is it sounding familiar? So unfortunately, we show that mothers of children with a life-limiting condition have higher psychological morbidity, which probably isn't a surprise, but they also have higher physical morbidity and higher risk of premature mortality than parents of children with other long-term conditions or mothers of children with no long-term conditions. We know from our qualitative work that their experiences are challenging, but that's mostly about the system. It's their interactions with the system. If you make them sit and fill in 45 pages of paper to access the equipment they need to meet the basic needs of their child, not only is that cumbersome and a waste of time, they're also not spending those 4 hours with their child. And that child has a short life. The opportunity costs here are huge. And we know that it's slightly different for fathers, some great work from one of my PhD students. And fathers often feel excluded from some of the healthcare conversations. They're trying to balance that working role conflict that they have for many. And we are starting to do something about this. So many of you may be aware of the Care Sports Needs Assessment tool, which came from adult palliative care and has some evidence of effectiveness within the adult world. And we've adapted it to add a domain around education and access to education. We have outcome measures that we can use. We just need to, and I just need to get on and do the evaluation. It's interesting, both our previous speakers have talked about measuring what matters. And if we go back and think of Donna Bedian, again, I think we're pretty good at measuring structure and process. We know if we've got a palliative care team, we know how many times children come into hospital or how many consults they have, but we're not so good at measuring true outcomes. What actually matters? What are we doing that changes things for children and families? So four or 5 years ago now, we published a mixed method systematic review of both the access to and impact of specialist paediatric palliative care for children and young people with cancer. And there was more than 40 studies, again, of low and moderate quality that showed that there was some evidence that the impact of specialist paediatric palliative care reduced in less intensive care life, more advanced care planning, and fewer in-hospital deaths. But there was less conclusive evidence on quality of life for children. We were very struck by the number of papers here, again, thinking of what Prasanna said earlier, measuring the number of times you've been in hospital, whether you've been to ICU, whether you've been ventilated, etc. And was that what was important to children and families? So we took these data to the UK Childhood Cancer Conference, which is a parent-led conference. Professionals are present, but it's a parent-led conference. And we asked them about what mattered to them before we showed them the findings of the review. And we asked them to rank. And they were also allowed to create new findings. And what you can see there, so I'm struggling to read, this is a problem, not great eyesight, but parent understanding, child quality of life, and family quality of life were what were important. They weren't that interested about whether they were in hospital or not. The things that we measure, because they're easy to measure, are really not as important to children and families. We have to caveat that with that might be important to your health system and to your commissioners that Richard mentioned earlier. But let's be really clear about when we're measuring what's important to children and families and when we're measuring what's important to the system. So we're just in the last year of the Enhanced study, which is the first national study in the UK of end-of-life care for children and young people, and this is a mixed methods evaluation. I'm hoping some of you have heard some of the team's talks. Julia was speaking yesterday about parent experiences and is speaking again this afternoon about professional experiences. But the last part of the study was a prospective study collecting data around the end of life, and we were trying to work out what do we measure in terms of parents' experiences in a more quantitative manner, having already done our qualitative work. So again, what does matter to parents? And this was a small study led by Julia Hackett again in York, looking at what matters in terms of palliative care for parents. And they want something that's co-led, co-planned, integrated, responsible. But they also really want to parent at the end of life. I'd ask you all to think of the last time you read a strategy or a document that mentioned around end-of-life care for children and young people that mentioned supporting parents to be parents. Because when we did a qualitative evidence synthesis of all the existing literature on parents' experiences around end-of-life, that was by far the overarching theme, this profound need to continue to be a parent. Now, what that meant, if you were a first-time parent and your baby was in NICU and was not going to survive, was quite different than if you were a parent of a 21-year-old in PICU who was going to die, but you'd been told they were only going to live till they were 1, and now they were 21. So again, thinking about the parent's role, but we also have to help them enable to be parents, not just healthcare providers. So then we thought, well, how can we measure this? And we did a scoping review led by some colleagues in Sheffield, looking at the existing measures of quality of death, of dying, and whether there'd been any sort of psychometrics done in our population. We only found 11 tools. Only 6 had undergone any sort of psychometric testing in the paediatric palliative care setting, and there was only 4 tools which looked at both cancer and non-cancer. But there was nothing about parenting in any of these. There was quite a lot about quality of life and preparation for death. The cultural aspects of care were very, very sparse within these. And actually we decided that none of them were fit for the purpose that we used. But thankfully there was another team in Southern England who were developing the Voices C questionnaire, which hasn't had formal psychometric evaluation, but certainly has face and content validity, and they've done some cognitive testing. So not ideal, but better than not doing anything. Yeah, am I going the wrong way? So, robust evaluations, you've all seen the hierarchy of scientific evidence, I'm sure. This is my preferable one, okay? So, it very much depends on the question that you're answering. And this one's especially for Myra, so you can have high quality, qualitative studies in that blue bit, if that's the question that you're trying to answer. They don't appear anywhere in the other triangle. But also you can have randomized control trials in the red bit as well. But I do think we need to be really clear. If we want to, we've already heard several questions about whether things are effective this morning. If we want to be able to assess effectiveness and cost effectiveness, we need to be using robust evaluation designs. And this is the updated Medical Research Council in the UK's guidelines on complex interventions, highlighting 2 things. Context is really important. We're working in a paediatric palliative care context. We need to think about that. But also evaluation, the evaluation design needs to meet the question. And that's not always going to be an individual level randomized control trial. It might be a realist evaluation. It might be a cluster trial. But it has to meet the question that you're trying to answer. And it has to be of the highest quality. And I'm going to talk a little bit about how special we are or not in paediatric palliative care in a minute, but I think we haven't taken advantage as much as we could of adapting interventions. And again, these guidelines that fit with the MRC guidelines talk about actually it might be more efficient to be adapting an intervention that already has effectiveness in another population. And that's what we did with the Care Support Needs Assessment tool. It had some effectiveness and information in adult world, and we have adapted it for pediatrics. But they also make a really important point that just taking a tool from a different context and trying to implement and evaluate it in a different one is not likely to be as successful as taking the time to think and assess whether you need to adapt for the context in which you're working. If I had £1, maybe even $1 or €1 for every time somebody told me paediatric palliative care is special and we have to start from the beginning and we have to do it differently, I'd be living here on the bonny banks of Loch Lomond in my log cabin and not spending all day in front of a computer screen. For those of you who are interested, there is actually a children's hospice just round the corner, one of children's hospices across Scotland. But we aren't as special. We need to work more with other colleagues. It's fantastic to be sharing the stage with a paediatric oncologist and a grown-up academic, because I'm not sure that 10 years ago we would have done that. And I do want to make a note just around adult palliative care and around the CPAWS study in particular, Richard. I think you've been very polite. I remember that first meeting of the 30. I was one of the 36 academics. I wasn't working with Richard at the time. I think it's fair to say we didn't welcome you with open arms. We were suspicious, we were highly critical, and we challenged you. And oh my goodness, have you stood up to the challenge? The team is fantastic. That is, I think, the largest prospective primary data collection study in paediatric palliative care, and it actually really, really matters. So thank you for sticking with us and not listening to the go away, you're a grown-up, you don't know what you're talking about. And, you know, I think that is really important. And Dame Cicely has said the same. I'm going to struggle to read this out now, but this was, gosh, way back in 1968. It's never wise to speak from anything other than one's own experience, and I have to admit from the beginning that only rarely do I care for children with terminal illness. However, I have been looking after those dying in all other ages, and whenever I've discussed our problems, I have found them remarkably similar. I think we also have lots to offer adult palliative care as well. They're now struggling with multiple health conditions, parallel planning, things that you guys have been doing for decades now. Working together is real value. If you'd asked me 10 years ago if I'd been working in an academic unit with grown-ups, I'd been like, no, what do they know? But the value is huge. I'm hoping that some of you have been at either Laura and or Prue's talks yesterday talking about the role of patients, parents and public in our research studies, not participating in them, helping us to design them, helping us decide what the important question is, how do we recruit to our studies, and how do we do that in an inclusive way, because it's already been said that nothing about us without us is so, so important. So the way forward for the UK, I'm really pleased to be able to say that we are about to embark on a large programme of work at adapting and evaluating interventions for children with life-limiting conditions and their family. We are going to be using interventions from the adult world. We're also going to be using robust evaluation designs, be cluster, step, wedge. We want high-quality findings here. We will be measuring what matters and also the economic evaluation. I know there's one economist in the room, but we need more. We need to really be able to give the robust evidence to the decision makers about how we go forward with further developing our services with our very changing population. So my conclusion is we've got lots of opportunities. We've already seen some great examples of robust evaluations being feasible and being undertaken in paediatric palliative care. But we need to work together across, for sometimes internationally, for some of the questions we want to answer, but certainly nationally. And we must work closely with the children and families that we care for. And I kind of think we're the limitation. I don't think there are many others, but we're also the opportunity. So thank you for listening.
Thank you, Lorna. That was a whirlwind tour, and which leaves us with lots of time for question and answer. Anybody wants to start? It often warms up very slowly. Just raise your hands. Yes, Joanne. Excuse me, just here.
Thank you to all three of you. It's music to my ears to hear what you have to say. I'm curious, Lorna, since you teased us with what's to come, do you have a sense of what types of interventions you're adapting and what questions you're going to be asking in this next phase of your research?
I do. It's supposed to be embargoed, so I'm not sure if telling 300 people in an audience is allowed, but I'll do it anyway, don't tell anyone. So the first thing, we are going to be going ahead with the evaluation of the Carer Support Needs Assessment tool within our children's hospice sector. We're also going to be looking at the role of the impact of short-term input of specialist paediatric palliative care. So there's some excellent work from Professor Catherine Evans, who's done some work in older adults in the UK that's shown the real value of that. And certainly I think for some of the children whose future is likely to be longer, I know that's not always easy to say, but the medically complex group in particular, there are times where short-term input of expert symptom management, etc., and getting the right team round, and then withdrawing and allowing the primary team to continue and coming back when you're needed may be really valuable. Sibling support is the other is the other area that is less developed, but really, really important. It's always top of the list whenever we speak to parents about what they want next. They never are. Support for them never is, because they don't think of themselves, but siblings, yes.
Thank you. David, this side. Coming. He's faster.
I wonder if we could get a show of hands of whose programs are routinely, systematically collecting patient-reported feedback, patient-reported outcomes during the life of the child. Put your hand up if your patients are systematic, or your programs are systematically doing it. And then perhaps after the death of the child, systematically collecting family-reported outcomes on end-of-life care. Thank you. That was for my curiosity more than anything else, but it's a major dearth, and I can't help but wonder. I also come from an oncology background, and there's the Children's Oncology Group, which really helps direct our efforts to be to work together, to choose sort of one question at a time and work together to answer it in a systematic way, rather than developing tools here and tools there and tools there, which may be overlapping, or if they're population specific, then it creates a challenge. Do I have a tool in my center for oncology kids, and a tool in my center for NICU kids, and a tool in my center? So I hear about collaboration, and I wonder if there's a role for the community to come together to systematically work through how do we prioritize what tools we're going to trial, and how do we do that together, and move the field forward so that we're all doing what we want, which is hearing systematically from patients and families, and using that to drive clinical care.
Yes.
Richard, do you want to say something? Obviously, I regard him as like, even though he works across both the adult and the pediatric world now, increasingly, I found him always, I look at him almost like a guru of outcome assessment tools. And I wonder what you have to say about this, because it's actually the same sentiment I have after listening to very many people speak about wonderful work that they do in different places, within different contexts. And for a small fraternity like ourselves in pediatric palliative care, can we all align and choose one, maximum two, that we can agree to apply, share experiences around challenges of implementation, and hopefully in the future share the data that we can then, whether it's compare, learn from, or utilize in different ways the findings from the data.
And if we can't agree on one tool, we can do a randomized control. You are, of course, entirely right. That would be the most...
Canada versus UK versus Singapore?
It would be brilliant to have a core measure, and it's interesting. So as several of you said, I worked mainly in the adult world in my career, and in the adult world we did a review of measures being used in practice and research, and there were well over 100 being reported. The vast majority of them use less than 2 or 3 times, so everybody's using something different. But I would also say it's not an easy thing to choose. How, in this room, how would people make that choice? If you don't, why would people know psychometrics? You don't need to know psychometrics, but you need to know somebody who does, so that can help you choose the right tool. What is that process for selection? And how can you have some certainty that the tool will do what you need it to do? So what we've tried to do always, to develop a valid and reliable core outcome measure, so measuring what matters, and then wherever we go in the world, slightly doing adaptation work. So, for example, the refugee work with children in the Middle East, social networks became really important, because if you are all of a sudden in a different country with a dying child and you're outside of your social network, your health system, that social connectedness is absolutely crucial. So that was a new item that we developed there. With Julia, in the African version, there's a lot of crossover in the UK in the African version, but there's slightly different items which are probably more socio-economic in Africa. So it's about all using something core in the same way, but having some adaptation as well is really important. So Lorna and I are working with somebody in China at the moment on children's outcome measurement and slight adaptation for that. So it's about having the core, working with people that can help you make that choice, and then doing some adaptation.
Can I add to that? So going back to our kind of learning from the adults, I think, Richard, I think you were part of it. There was a global collaboration for outcome measurements in the adult. And we were looking at countries around the world and what outcomes were used and what was similar around the world and what wasn't, and how we were collecting data and things. So there'd be stuff we could learn from that collaboration within the pediatrics. And also just putting in a plug for all the other countries, the low-income countries, and getting their input as well.
Can I carry on the conversation? I think it's an amazing aspiration, and I also, just from trying to do research in across institutions where there's no infrastructure, and that's in the United States, I think we also need to think about implementation and expense and resources to be able to measure what matters systematically and routinely. And I don't know, but I would ask our panelists, and maybe Prasanna, you can comment on perhaps the future of the PACE questionnaire with regard to implementation and routinely being able to use it in children with cancer.
I think it's a huge problem. So just sort of echoing your sentiments around the Children's Oncology Group and how they've formulated a transnational approach to executing clinical trials, there's so much bureaucracy. And in my limited experience in developing this questionnaire, I worry a lot about implementing it across, even just within the United States, across institutions. There has to be buy-in at all different levels, and a sense that it's actually adding something meaningful to their practice. And so some of the things that I'm thinking about, again, also in a research context, are interviewing some of these leaders and executives in hospitals, presenting them with some of these quality data and seeing whether they would, in fact, respond. And I do worry a lot about not having sort of the metrics that hospitals care about, unfortunately. You know, we would like to think that they care a lot about patient experience, and in theory they do, and in terms of our ability to manage symptoms and communication, et cetera. But when we don't present some of those hospital level data, I wonder if institutions will care. So that was actually a question I was going to ask Richard in terms of implementation, and this was sort of a theme that had come up in several of our discussants. In terms of implementing the CPOS, what are your goals, or what are your hopes in terms of when and how people will actually utilize the instrument?
Yeah, thank you. So, yeah. Outcome measures on their own won't change anything. The implementation can change a lot. So it's really crucial. So we've done the review of implementation broadly in healthcare for child health. We've done the qualitative work. We did a theory of change workshop with parents asking and healthcare professionals. So there is a model of how it should work. But the goal, I mean, it's interesting. My fear with an outcome measure, because people generally want to be doing the right thing and are generally excited and engaged. So the risk is always that you see the outcome measure, you start using it, but without a plan, the likelihood of failure is quite high. So what I really like the idea of is demonstration sites. So you get a few centers to develop their implementation plan, work with it for a year, and then in a forum like this, come together and say, look, this is how we did it. This went wrong, that went right, we like this, we didn't like that, this is how it worked, we like it for these reasons. And then start rolling it out, because that careful, thoughtful implementation, because models, I mean, Lorna alluded to models of care earlier. You all do very, very different things for the same goal. So you have to have implementation plans for very, very diverse models of care in oncology clinics, in communities, in hospices, wherever care is being delivered, you need implementation plans that are going to work for that. So it needs to be done thoughtfully and carefully.
Any last questions before we close for tea? Yes, one more.
This is more a comment rather than a question. Prasanna, I was really interested that you used bereaved parents in your study. My name is Breffney McGuinness. I'm from Laura Lynn Children's Hospice in Ireland. We've recently started using a grief map assessment with the parents that we work with. It's developed by Linda Machin, and it's in pilot at the moment. One of the things that we found with parents who are bereaved is one of the items in that scale, which is how your child died. So the actual experience of the death of the child. A lot can happen beforehand, but it's the actual experience of the child dying that makes a difference. And what we're noticing is we're getting more people coming to looking for services where that experience has not been great. There may have been a lot of really good care beforehand, but the actual time of death, it might have been an admittance to a hospital, to an ICU, to an emergency department. Something may have happened. What parents are left with is that piece. And I suppose the comment that I have is just the importance of doing the kind of assessments that you're talking about from the point of view of the long-term care afterwards of families and their ability to integrate or come to terms with, as best they can, what is a really, really difficult loss. So I suppose that bit of what happens right at the end really matters in what we're seeing. Obviously, there needs to be more kind of studies around that, but maybe to encourage what you're talking about in terms of the assessments you're doing, and also to keep our eyes focused on those pieces. Thank you.
Thank you for the comment. Really, it's around recency bias. Sometimes you can do a very good piece of work for many years, and then when the dying becomes less than perfect, it can then influence the final, perhaps, perception of how care was like throughout the whole journey. But then, again, with so many tools, which one suits you? Which one is feasible? Which one is meaningful? The jury's still out. Until then, I hope that you'll all agree with me that this was a very rich and vibrant discussion, and I want to take this opportunity to thank our three distinguished speakers for a very insightful sharing this morning. Thank you very much.